Hello, welcome to the web-based learning opportunities hosted by the Collaborative Family Healthcare Association and supported by both the California Mental Health Services Authority and the ARC Academy for Integrated Healthcare. The Collaborative Family Healthcare Association is a nonprofit, member-driven, collaborative organization in existence since 1995. We believe deeply that collaboration is an essential element for revisioning healthcare. We promote a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individual and family, patients, providers, and communities. As mentioned, our webinar today is sponsored by the California Mental Health Services Authority in partnership with the ARC Academy for Integrated Healthcare and the Advancing Care Together program of Colorado. The California Mental Health Services Authority, or CalMESA, is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded by counties through the Voter-Approved Mental Health Services Act, or Proposition 63. Prop 63 provides the funding and framework needed to expand mental health services to previously underserved populations in all of California's diverse communities. We are so pleased today to have you join us for our webinar, Statewide Integration Efforts in Policy and Practice. We'll have perspectives from Kentucky, Pennsylvania, and Texas. I'd like to take just a minute to introduce you to our three speakers today. Representing Kentucky, Gabriela Alcalde is a health policy director at the Foundation for a Healthy Kentucky and works primarily in the Promoting Responsive Health Policy Initiative. Gabriela has diverse public health experience in the government, nonprofit, academic, and community sectors. Our next speaker representing Pennsylvania is Natalie Levkovich. Natalie has held the position of executive leadership at the Health Federation of Philadelphia for nearly 30 years. HFP is a consortium of community health centers in the greater Philadelphia region, providing care to nearly 300,000 vulnerable and underserved individuals annually. As a leader of this nonprofit public health organization, Natalie has played a critical role in the convening and connecting of organizations in the public and private sectors and mobilizing resources to expand service capacity and increase access to care. And finally, Dr. Lynda Frost of Texas serves as the Director of Planning and Programs at the Hogg Foundation for Mental Health, where she oversees major initiatives and grant programs, leads strategic and operational planning, and manages program staff. Dr. Frost is an experienced administrator and attorney with legal expertise in human rights, juvenile justice, criminal law, and mediation. She also holds an appointment as a clinical associate professor of educational policy and planning at the University of Texas at Austin. Please join me in welcoming our esteemed speakers. Before we get started today, I'd like to just take a moment and do a little bit of housekeeping. For those of you attending, you'll see that in the upper right-hand portion of your screen, you'll have a control panel. During and immediately following the three presentations today, we'll have an opportunity for questions for the speaker. As you can see, you'll have the opportunity to either write in a question that we can read, or if you choose to do so, you can raise your hand and I can unmute you and you can ask the question verbally. And depending on time, we'll try to get through as many questions as possible. To start off our presentation today, we wanted to give you just a little bit of introduction to CFHA and our policy agenda as an organization. CFHA bases its policy decisions and its agenda in looking at basically the problem of fragmentation in healthcare. We believe that fragmentation is pervasive and most commonly and negatively seen in the artificial separation of mind and body. There's fragmentation in payment delivery systems, and it's not supported by team-based care. We believe that the redesign of primary care through the patient-centered medical home doesn't adequately recognize, require, or compensate for mental health, behavioral health, and substance use. So toward those lines, our policy initiatives and beliefs and what we try to work within each of our policy summits looks at promoting policies that foster that integration and break down those barriers of fragmentation. We want to integrate funding. We want to ensure that the principles and criteria for the patient-centered medical homes include comprehensive mental health, behavioral health, and substance abuse. It's important to us to establish and promote and educate patient-centered medical home initiatives on how inseparable mental health, behavioral health, and substance abuse is in those initiatives. And finally, it's very important to us to look toward the patient and the family as the center of healthcare, and then surrounding that patient with the appropriate and comprehensive services to meet their needs. So as we get started, we'd first like to look to Kentucky and welcome Gabriella, and she will walk us through what's been happening in Kentucky since the 3 years since our policy summit. Gabriella?
Good morning. Yeah, good morning or good afternoon, everybody. As Polly said, this is Gabriela Alcalde. I'm with the Foundation for a Healthy Kentucky. We're a nonprofit foundation, and our mission is to address the unmet healthcare needs of Kentuckians. We do so by addressing issues at the policy level and the environmental level with the goal of improving access to care, reducing health risks and disparities, and promoting health equity. I wanted to provide just a little bit, and if you could move the slide.
Sure.
So I would be on the third slide.
Okay, thanks, Gabriella.
There we go. One more.
One more.
Mm-hmm. So I wanted to provide just a little bit of background, just to provide a context of where integrated care fits within the work that we do. We have 3 overall initiatives at the foundation. The 3 initiatives were launched last year. We have 5-year-long initiatives. So the 5 years started in 2012. The first initiative is the one that I'll be talking about briefly that contains integrated care, and that's the health policy initiative. The second one, we have one that focuses on children's health, and it's a place-based initiative throughout the state. And then we have an initiative around community engagement and outreach. So the one that I lead is promoting responsive health policy, which is an initiative aimed at making policy more responsive to both the health and the healthcare needs of Kentuckians. That has 4 focus areas that we're working with partners, grantee partners. And the first area is promoting policies that increase access to safe and effective integrated care services. And you'll notice that we provide a definition of integrated care within this initiative as primary care, behavioral health, which includes substance abuse, and oral health. I'm not going to spend much time on this because I think all of you know about integrated care, but it's more of a sort of disclosure. There are so many different ways of using the term integrated care. So we look at the whole continuum. We know there are different ways that this is being done in Kentucky. And acknowledging the different ways that people go into it and the different paces and sort of the different continuum places in the continuum where they are. But we do believe that integration, should pretty much provide a seamless, coordinated, and systematic approach to addressing a whole person. And we also, in our issue brief and our white paper, talk about working with the family, other care providers, and the entire community, so really having a community-centered approach. So why did we decide that this was a priority? And this is something, as I talk about the history of our work in this, you'll know that we've been working on this for nearly 10 years, or about 10 years. First, because our goal is looking at changing the way that healthcare is delivered through financing of healthcare services through delivery. We're really focused on achieving the triple aim of improving an individual's experience through quality and satisfaction, improving the health of populations through prevention and other public health approaches, as well as reducing the cost of healthcare. And we believe that integrated care is a necessary tool to achieve this. We don't believe that you can achieve the triple aim without integrated care. 2 other areas that we're very focused on are access to care. And we believe that, again, integrated care is a key tool to increasing access, both for folks who have existing behavioral health issues, but also just provides a more comprehensive whole person approach. And finally, access and equity are, as I stated earlier, two of our main goals. So those are areas that we believe are addressed through integrated care. And again, this is obviously speaking to the choir, but the human toll, we know that the quality and the length of life is diminished for people who do not get appropriate care, and the effect on families. We know that there's a great economic cost in terms of healthcare, productivity, and also other systems, like unfortunately the criminal justice system and other systems that get involved when people do not receive appropriate care in the appropriate time, in the appropriate place. And finally, we believe that there's a great degree of access and equity because there's an unequal distribution of risk factors, knowing that poverty, isolation, negative childhood exposures, including violence, are risk factors for substance abuse and for the deterioration of some mental health conditions. We see that communities of color, as well as immigrants and refugee communities and rural communities, particularly relevant in Kentucky, are more likely to be exposed to these risk factors. They're also more likely to seek behavioral health and primary care settings. So we believe that integrating care is important to addressing the disparities and improving health equity. So I wanted to provide a little bit of the history of the Foundation's work in integrated care. As I said, we started nearly 10 years ago, in fact 2004. In 2005 was officially when we started doing funding work. In 2005, we provided 6 planning grants to different locations that we used a sort of a planned variation approach where we looked at locations and entities that were trying to achieve integration through different settings with different populations so we could learn the most about what worked. And out of those 6 planning grants, we funded 4 demonstration projects, and that work went on until 2011. In 2009, we recognized that it was very important to have a statewide involvement of professionals both in health and in healthcare who had a commitment to increasing access to care for the whole person. And we called this the Integrated Care Action Team, and that group is still active, and they meet not too regularly, but we do communicate through electronically, and we bring them together for any major event or report that we do. In excuse me, in 2010, the Foundation hosted the CFHA conference in Louisville, and we held in conjunction to that policy summit to address care integration as well. The ICAT team that I just mentioned published a report called No Wrong Door, Bridging Mental Health and Primary Care Silos in Kentucky in 2010, which included some specific recommendations for change at the state level, including regulatory and policy changes. Last year, as I said, we launched our Promoting Responsive Health initiative, and integrating care is one of those 4 focus areas. Last year, we also, as part of our annual health policy conference at the BOST Policy Forum, the entire conference was focused on integrated care, and we brought in national as well as local and regional speakers to address community leaders and care providers from the state on ways to move the policy spectrum towards integrating care. Some specific work that the Foundation did last year as well, we issued a white paper that's pretty comprehensive, and then also an issue brief that's much easier to read, and it's only about 8 pages as opposed to the 70-some of the white paper, sort of updating the report that the ICAT had issued in 2010. So we're trying to keep current with everything that's been going on in Kentucky. And as a result, we were invited in 2013, earlier this year, to be part of a state-led integrated care learning community. And we can go to the next page, the next slide. Thank you. This was a great opportunity, and one of the things that the reason I wanted to call this out for the presentation, we felt really good about the work that we've been doing, and that we were invited to the table with the state when they applied for this opportunity through the National Council for Behavioral Health. It was a 6-month process, and it included, as I said, mostly the state-led folks, but also providers throughout the state and provider associations from both behavioral health and primary care. and some advocacy groups. So it was a great experience, and the foundation was really honored to be a part of that and to help develop, again, some policy recommendations and direction that have been presented to the Secretary of the Cabinet of Health and Family Services. So we are at this point waiting to hear on that, but it's, again, one more step. And this is, we believe, part in result of the ongoing work over the last 10 years. It's a lot of the same people from the ICAT team that have been coming together. So this is, again, one more step towards creating those policy changes at the state level. I think key to the work that we've been doing has been the role the foundation plays as a convener of key players. We are often able to bring people to the table who normally don't meet together. I know that in the past, when we started this work, we were surprised to learn that some of the professional associations had not, in fact, met together to discuss some of the issues around integrating care. And so we are able to sort of step back at the state level and figure out who needs to be at the table. And again, this is just a list of some of the folks that we have worked with and continue to work with in terms of how can we have an open discussion about the barriers and work towards overcoming those barriers. And we know that there are some policy changes that need to be made, but there are also some cultural workforce changes, and just with all of the tremendous amount of change that we're having right now at the health policy level. And that brings us to the next slide. Kentucky is a pretty unique state. We're a southern state, but unlike our neighbors, we have established a state-based health exchange called Connect, and we've also, our governor has chosen to expand Medicaid. So, and then at the end of 2011, we also transitioned our Medicaid program to Medicaid managed care. So these have all been opportunities as well as challenges. Each of them have presented both of those in working with Medicaid managed care, and the opportunity because they did not carve out behavioral health, which had been the case in the past in Medicaid in Kentucky. So there's been some growing pains, but certainly the opportunity by having both physical health and behavioral health within the same NCO provides the opportunity and the promise of integrating care better for all of our communities across the state. We also know that we have opportunities through the Affordable Care Act as we are seeing all of our providers madly trying to implement both the exchange and expansion, doing outreach and enrollment. So we know that substance abuse coverage is included, and now mental health and substance abuse use coverage parity, preventive care without cost sharing, Medicaid expansion, which includes mental health mandated benefits. We also feel that the accountable care organizations offer the opportunity for a whole person approach and funding to develop community health teams through the Affordable Care Act. We have the exchange, and Kentucky has been doing a lot of work with health information technology with a rural state like ours. Telehealth is a huge issue. So we see that as a tremendous opportunity to improve integrated care, especially for a rural population. And I see that my time is about to run out. So I just wanted to hop onto the next one and update. In terms of, we have a lot of sort of a rapidly changing policy environment right now, as well as rapidly changing in terms of the delivery of care, and even the intermediaries in terms of Medicaid managed care organizations have just been announced. So since we started our work in 2005, we have had, and then certainly since the report in 2010, we've had some changes, some more significant than others. The biggest one is the new regulation on telehealth, which really improves our ability to provide behavioral health through this technology. It has changed some of the reimbursement regulations, so this has really opened the door for more facilities to do this. Since 2010, one of the recommendations has been to use peer specialists in behavioral health services. While that has not been changed within Medicaid at the state level, some of our managed care organizations are currently reimbursing, and there have been ongoing conversations at the state level looking at maybe making this across the board for all MCOs. Next slide. And finally, just in terms of the future of integration, with the implementation of the Affordable Care Act, all the different incentives that come with that, and the required need to change the way that care is delivered, the way that care is financed, the way that we approach individuals for moving away from sort of the treatment only and moving more towards a whole person and more preventive approach, looking more at population health management. We're looking at changes that we need to take place at the policy level. Some of these are at the federal level, some at the state level, and some of these are need to be implemented at the local level. Obviously, with financing, confidentiality issues in terms of information sharing, continuity between private and public insurance, especially as we expand into the exchange and Medicaid expansion. There will be some fluidity or some churning between those systems, and we need to make sure that people can maintain continuity of care with their providers, whether they go into the private insurance system or the public insurance system. Make sure that we have workforce readiness, and that's both assuring that we have sufficient workforce, and that's a problem that Kentucky is facing, particularly in our rural areas. We do not have sufficient primary care providers or behavioral health providers, so that's an issue that we really have to raise, as well as the cultural workforce changes necessary to integrate care and to provide seamless care. Medicaid managed care, again, we've had a bit of a bumpy road implementing Medicaid managed care, but it offers great opportunity to provide both behavioral and physical health through one contract as opposed to subcontracting it and not having those systems speak to each other. Most of all, though, in working over the past many years and working with the health leaders with the ICAT team, I think everybody agrees that the most needed thing is a shared vision for integrated care and political will and leadership to make this happen. So with that, I will close to allow my fellow presenters to have their full amount of time. Thank you.
Good. Thank you, Dr. Alcalde. It's clear that Kentucky is moving forward in some big ways, but we all agree that that shared vision for integrated care is one of the most important things in any states and throughout our collective work. I'd like to turn the chair over now to Natalie Levkovich from Pennsylvania. Natalie?
Thank you. Hi, everybody. As Polly said, I'm the CEO of the Health Federation of Philadelphia, a consortium of community health centers in the greater Philadelphia region. Our work primarily focuses on supporting access to comprehensive primary care for residents of the local region. Since 2006, the Health Federation has facilitated the development and spread of primary care behavioral health practice, workforce training, and payment reform in our southeastern Pennsylvania region. So I will be talking somewhat from that point of view, although I have certainly am connected with and gathered input from colleagues from across the state. This presentation is in no way a complete or definitive summary of all that is currently going on in Pennsylvania, but it is a sampling of the progress that we have made over the last several years and work that is still ongoing. So in 2011, I was co-chair of the annual CFHA conference, and the theme of that conference was accelerating adoption of collaborative care. And that's pretty much what's been happening at our local level as well as nationally. The summit, attended by about 85 people representing clinical, policy, payer, community, and other stakeholders, was only one of many catalysts that have accelerated progress in Pennsylvania. So there's a considerable amount of good news to share since integrated care has been spreading and expanding in the state pretty steadily. That progress is incremental, as it usually is, and practice, in many cases, gets ahead of policy changes and results in the need for creativity on the part of providers. But those providers have found creative ways to collaborate, and local foundations have been supportive of pilots and innovations and advocacy in that area, and I will say more about that in a few minutes. So, speaking for the Health Federation, under the auspices of the Health Federation in the Philadelphia region, we now have, and I can update it since I made these slides, we now have 23 medical sites with embedded behavioral health consultants. And these include HIV practices as well as comprehensive primary care practices, mostly FQHCs. We now have about 38 behavioral health consultants who meet together as a community of practice on a regular basis and support each other, continue their professional development, maintain through that contact, through that mechanism, fidelity to the principles of integrated care. Two of our local counties we do have carve-out behavioral health managed care. And in two of our counties, those managed care organizations have developed fee-for-service mechanisms within the FQHC environment. While 2 counties is not a lot in a state with 67 counties, it does make it easier to have the conversation county by county once the precedent has been set. Fee-for-service, of course, has its challenges, but it does make it possible for providers to take the plunge into integrated care. So in Western Pennsylvania, the Pittsburgh Regional Health Initiative is a supporting organization of the Jewish Healthcare Foundation, which is itself an advocate for integrated care and many other healthcare improvement initiatives. One of PRHI's signature initiatives is called Partners in Integrated Care. And with their leadership and with federal funding, a number of primary care practices have integrated evidence-based and evidence-supported behavioral health interventions, as summarized on this slide. Health centers across the state have integrated behavioral health staff into their primary care practices, either through hiring or through contracting with community mental health. There are a variety of such models being adopted. Again, in southwestern Pennsylvania, the Staunton Farm Foundation has funded a number of such projects that include integration of behavioral health in-home health programs, a clinic for homeless youth, a doula program, services program for pregnant women, just to name a few of the kind of creative ways that integration is occurring. Likewise, there are numerous examples of community mental health centers collaborating with medical providers to bring services to their seriously mentally ill populations, and I'll say a little more about that in a minute. So continuing, more good news. Next slide, please. The Pennsylvania Physical Health, Behavioral Health Learning Community, established as a coalition among professional associations, continues to grow and provide a variety of activities to support that community. These include virtual convening, a clearinghouse of relevant information, regular communication regarding training opportunities and developments in practice and policy, as well as a collective voice for advocacy. The Pennsylvania Health Funders Collaborative is a coalition of local health foundations, statewide, and they have been very invested in promoting care integration. by piloting, by funding pilots and various innovations. They have commissioned and funded local studies on the state of integration across the state, that is examples of ways, models and strategies that various communities are employing. They've really been, we've really been quite fortunate in the impetus that foundations have brought to this effort. It's important to note that private philanthropy has been instrumental not only in Pennsylvania but across the country. Our own Health Federation initiative got our jump start back in 2006 or 7 thanks to an Aetna Foundation grant. And you'll notice that my co-presenters today both represent private foundations. So, community mental health providers, community mental health centers have also been working on integration. And they have done so by contracting with medical providers in their communities, often FQHCs, hiring their own nursing staff, creating mobile teams to serve their SMI populations to promote collaborative care. There are dozens of these examples across the state, notably in southeastern Pennsylvania. In my neck of the woods, 2 counties, Delaware and Montgomery counties, have been for a number of years very involved in this effort of integrating medical services, primary care, into mental health through funded pilots, collaboration among MCOs and county health units, and engaging community providers in those efforts. And where fee-for-service has not been established, flawed though it is, state waivers, philanthropic investments, system reinvestment dollars, and organizations and institutions' own operating resources have been used to support these programs. So now there's more promising news. What I just told you were things that are in full operation and are good news. Now more promising news. There are policy developments that hold promise for adding to this momentum. So, for example, a physical health MCO called Health Partners of Philadelphia has embraced the model of full integration, made it a core component of its recently submitted grant for CMMI funding. The Philadelphia AIDS Coordinating Office has fully embraced integrated care and submitted application for funding to SAMHSA to embed behavioral health consultants in 6 HIV practices in Philadelphia. Now, whether or not these initiatives are funded or whether or not funding continues, this process wins the hearts and minds of decision makers and providers alike and begins a dialogue about sustainability, which is quite promising. The next slide, Philadelphia Department of Public Health, which operates 8 neighborhood primary care centers, FQHC lookalikes, is collaborating with a community mental health agency to hire and integrate behavioral health consultants into those settings. We think of the health department clinics as the safety net of the safety net. And the Health Federation will be directly involved in providing professional development, training, and technical assistance as they roll out that initiative. The Pennsylvania Department of Public Health has just completed a State Innovations Model Plan for submission to CMMI. The state planning process here has been very inclusive and therefore has incorporated a number of important aspects or ways, strategies around integrated care that include integrating behavioral health in the patient-centered medical home, in care management strategies to support the so-called high utilizers, and for integration of physical health in the community mental health setting to address the needs of the seriously mentally ill. In other words, our state is taking a flexible, person-centered approach, and the state also, as part of this plan, intends to create capacity for technical assistance and transfer of learning, again, to accelerate the momentum. So with all of that good news, there is certainly still more work to be done. Next slide, please. So clearly we're pleased at the progress made over the past several years. However, individual programs are still fragile from the standpoint of long-term sustainability. As long as they are grant dependent, of course, that instability continues. Fee-for-service, where it exists, which is not everywhere, does not fully recognize the scope of practice and benefit of integrated care, while strategies for bundled payment or gain sharing are yet to emerge. So one area of work clearly is payment reform to ensure sustainability. Workforce, that was already mentioned. Workforce is still in short supply. State licensing and credentialing policies for behavioral health providers in Pennsylvania is part of the problem. Another challenge is that training for integrated practice professionals is still in very short supply. While there are some online certificate programs that are quite good, regional professional development and technical assistance centers like ours are few and far between. And finally, a major barrier is this notion that behavioral health integration in primary care, of thinking of behavioral health as a program rather than as a way of delivering high-quality primary care. Administrators understandably focus on provider productivity and revenue, and as long as the behavioral health and primary care financing services are supported through segregated payment streams, it will be difficult for administrators of provider organizations to truly adopt a fully integrated view. So I will end there. In summary, again, we're very happy with the progress being made in Pennsylvania, and we are not letting down our level of energy and vigilance since there's much more work that lies ahead. I believe we've demonstrated a considerable attention span for this work because it makes sense and it makes a difference. We at the Health Federation have been working on this for about 7 years. The Pennsylvania Health Funders have held steady to their commitment for the last 5 or 6 years. The state is finding its way by steps to address policy barriers, and so tenacity is alive and well in Pennsylvania, and we have high hopes for more progress the next time we have a chance to update you. Thank you.
Thank you, Natalie. It is clear that tenacity is alive and well in Pennsylvania. You all have made a lot of progress, and it looks like, as you said, it's incremental, and I think that serves us very well in the long run. We'd like to turn it over now to Dr. Frost from the Hogg Foundation in Texas. Dr. Frost?
Hello, thank you. And thank you for the opportunity to participate in this webinar. Hogg so admires the work that CFHA has done and is doing to promote integration, and we also were honored to strengthen our relationship with CFHA last year by co-chairing the annual conference. So thank you for all that you do. We appreciate it. Today, my time is short, so what I've done is tried to build in a lot of links to this PowerPoint so that if listeners want to know anything more about any specific aspect, you can click through on the links. But in the time that I have, what I plan to do is to briefly talk about the history and context of integration in Texas, talk about the CFHA Policy Summit that was last October, and then touch on post-summit developments, what's going on in Texas in the, I guess, less than a year since we had the Policy Summit. So the Hogg Foundation prioritized integrated care back in 2005, and starting in 2006 started to promote and roll out activities to support more integrated systems across the state. We had a multi-year grant program that was supporting a range of organizations in implementing the collaborative care model. We focused specifically on that model because of the body of research supporting it, and had a fairly prescriptive program helping organizations that wanted to adopt that model in their own service provision. In 2008, we had a statewide conference that provided broader perspectives on integration. We had folks coming from around the state, and we also published a guide to integrated healthcare in Texas that came out of some of the information from that conference. We decided that we wanted to help more focused work on the part of some agencies. So in 2009, we began a multi-year learning community that was facilitated by the Mental Health America Houston organization. We ended up having 18 organizations from around the state that participated in that process to learn more about some of the theory, the models of integration, but particularly around what different agencies were doing to address and overcome barriers they were finding in integrating their practices. As I said, for all of these programs or interventions, there's more information at the links if you want to know more about it. And of course, you're always welcome to contact me. Statewide, Texas was unusual in that 2 legislative sessions ago, in 2009, our legislature passed a bill that was focused on the integration of health and behavioral health services. Part of what this bill did was to create a legislative work group. And Hogg participated on that and also provided some staff support. The mandate for that work group was to explore key issues and barriers to integration, to identify best practices, and to make policy recommendations for what could be done to promote integration across the state. The work group submitted a report back to the legislature in 2010, and after the work group was disbanded, there was an informal work group, I guess you could say, that was created because agencies really wanted to continue to meet, to look at what needed to be done across the state to promote integration, and to share ideas and challenges that they were facing. In a bit of shameless self-promotion, I'm going to mention an article that was published online last week, actually. I haven't seen the in-print version yet, that talks in more detail about this work group and analyzes its impact since its time in the state of Texas. The article is called Assessing the Legacy of a Legislative Work Group for Bidirectional Integration of Services, co-authored with Catherine Sanchez and Mary Held, and it's in the Journal of Behavioral Health Services and Research. So that's at that link that you see on your screen there. Another collaboration that Hogg participated in was with the U.S. Department of Health and Human Services Office of Minority Health. This was prompted by a recognition that health disparities are a pervasive and continuing problem in our country, and that integration of systems doesn't necessarily explicitly focus on what integration can do to reduce health disparities and how to do integration in a culturally competent manner. There's several products that came out of that collaboration. There is a report with consensus statements and recommendations, and there's also a literature review that provides, I would say, more detail than most of you would want, but knowing CFHA, some of you want all that detail. So those are available on our website, and we recently published a funder's guide providing suggestions and input from grant makers around the country on how funders can fund integrated healthcare projects in a way that is aimed at reducing health disparities. Finally, another important piece of the Texas context is an 1115 Medicaid waiver. It's called the Texas Healthcare Transformation and Quality Improvement Program. That is, it's changing the world in Texas, I tell you. It's really upended many things related to behavioral health service provisions, and therefore has important implications relating to integrated health care. So the waiver expands Medicaid managed care and replaces, changes some of the funding schemes. It replaces the upper payment limit program with an uncompensated care pool and, interestingly, a delivery system reform incentive payment pool that we call DSRIP. It really infuses significant additional dollars into the system, but it also reorients some of the incentives and motivations in ways that are challenging and very important to providers around the state. The waiver created 20 regional healthcare partnerships. So every county, all 254 counties in Texas, are part of one of the 20 regional healthcare partnerships. Those healthcare partnerships have developed plans for the 5-year waiver. So they've identified what programs they plan to implement. The approved spending limit for this waiver is $142 billion. Like I said, this is a big deal. So in the plans that the RHPs have submitted, there are 1,335 district projects that have been submitted. A significant proportion of those relate to behavioral health, and there are 48 that specifically are focused on integrating primary and behavioral health care, which was one of the key project areas. So as you can see, this is a lot of stuff going on, a lot of projects, a lot of change, but integration is a key piece of what these regional healthcare partnerships are trying to do. So that's a really essential part of the context. And that brings us to the CFHA Policy Summit. So we were really pleased at the opportunity to do a policy summit as part of the CFHA program. Because this waiver was already in process, it was a natural way to focus the summit. We ended up having a day-long summit because there was so much going on. And we focused on these regional healthcare partnerships and helping guide them in learning more about integration and building integration projects into their proposal submitted to CMS for what projects they wanted to fund. We ended up getting 17 out of the 20 RHPs represented at the summit, which we were thrilled with. You know, as y'all know, Texas is a big state, and we were pleased that people were willing to travel quite far to come to CFHA and learn more about this. We had expert speakers, many of whom are CFHA members, including our own Natalie. Thank you, Natalie. And the summit focused on examining issues related to successful implementation of integrated healthcare, looking particularly at improving outcomes and lowering costs, which is on the mind of everyone in the RHPs, and really aiming for people to leave with specific actionable steps to take to incorporate integration projects in their RHP project plans. Now, it was a pretty intensive day, but we recognize that you can only do so much in one day. So we were fortunate to have a CFHA Policy Fellow position created. Megan Longley served in that position, which was funded by the Meadows Foundation, a Texas-based family foundation, for a fellow to work half-time with CFHA to support ongoing work related to the RHPs and integrated health care. And that was, I think, a really important piece of support that connected the expertise of CFHA with the on-the-ground specific process in Texas in order to make sure that integrated health care was really in this waiver program to the largest extent possible. Since that summit, there are some more developments, and still a lot of the same. The 1115 waiver is the big factor in the Texas environment today. It is so significant, it's very complex, there's a lot of energy focused on it. Things look different in each of the 20 RHPs, so it's a complex thing to keep a handle on. But if you want to know where integration is going in Texas, this is a really important place to look. Additionally, coming out of our most recent legislative session, which ended this past June, there was a Senate bill that integrated behavioral health services into the state Medicaid managed care program. Some of those, particularly targeted case management and psych rehab, previously had been fee-for-service, and so this is changing the structure of that, promoting integration and creating a lot of complexities among various service providers in Texas. In part because this is a complex process, the legislation created a Behavioral Health Integration Advisory Committee, which will be in existence until 2017 to help oversee the integration process, which is supposed to be completed by, I think it's September of 2014. So this committee is going to address challenges that come up and work to make sure that this integration happens as smoothly as possible. Hogg has also been continuing to fund in this area. Ricky Barra is our program officer in charge of integrated healthcare, and he oversees a program with planning and implementation grants. Last year we spent almost $750,000 to fund planning grants for a handful of organizations and implementation grants for others who were at a point where they were ready to implement. This year, many of those planning grantees moved into an implementation phase. And for us, it's particularly interesting that many of these grantees are FQHCs, so their programs look a bit different than some of the other programs we had worked with in the past. Most interesting, there's growing focus on certified peer support specialists and roles that they can play in FQHCs as well as other service settings. So we feel like there's a lot of potential for increased and improved integration with the help of peer support specialists. This is a really quick once-over on what's been going on in Texas. On the next slide, you have my email address, so please feel free to email if I can provide you with any information or connect you to people who know far more about these things than I do. But thank you so much for allowing me to participate in this, and we all look forward to your questions and comments.
Dr. Frost, thank you so much for the presentation today. It's amazing how much can happen in a year since we were in Texas last year. You guys have really been moving along. We do have a couple of questions that have been submitted, and I'm not certain we'll be able to get to all of them. So if the speakers will all make sure you're unmuted. The first question we have relates to physicians, particularly psychiatrists. For the panel, what can physicians and psychiatrists do to expedite systems and policy changes, specifically from a physician perspective?
Well, this is Lynda. In Texas, psychiatrists play a key role. Because they head up treatment teams, they have a lot of authority to determine how different folks work together and who is on the team. So I think that they can do a lot of role modeling by how they choose to work and how they set up systems. I think relating to peer support, they can be tremendously influential in how peer support engages with treatment teams. But I think they also set the tone in terms of looking at a person's whole health and not just specific areas of health. So I think psychiatrists play a really influential and important role. I think the recovery to practice model that SAMHSA has out has a lot of potential for training in medical schools and other places, looking at the roles that physicians play and looking at some of the newer approaches. So that's something that people might want to take a look at.
Natalie or Gabriella, do you have a response, or let's?
Well, in locally, we have we've been fortunate to get some funding to allow psychiatrists to serve as consultants to health centers with integrated care programs. The reason that this requires grant funding is because the psychiatrists don't take on a caseload. They will see a patient on a one-time basis for assessment, and they provide a lot of curbside consult to the team. So one of the voices that we would like to have join in advocacy is the voice of psychiatry, to advocate for a consultative role in order to make integrated care not only possible but of the highest quality.
This is Gabriella. I would second what both of speakers have said, and just that in Kentucky there's a need for changes at the regulatory level. So I think certainly adding physician voices and psychiatrist voices to the advocacy efforts that are already underway in terms of changing regulations to allow for reimbursement and also just what professionals are allowed to work and be reimbursed within which facilities is really essential.
Excellent, thank you. It looks like we're very close to being out of time. There are a couple of additional questions relating to the MCO reimbursement for peer specialists and the Kentucky regulations pertaining particularly to telehealth reimbursement. We will specifically respond. I'll reach out to our speakers and ask them to specifically respond to that, and we'll post it on our website. The webinar today was recorded and will be posted both on the CFHA website as well as the ARC Academy website for those of you who are interested or want to go back to some of the resources shown on the slides today. I'd like to thank you all for participating and also remind everyone that the upcoming CFHA conference in Denver, Colorado will be this October 10th through the 12th. Our policy summit here in Colorado will be on the 10th. We're very much looking forward to that day and the outcomes from that. Again, thank you for participating. Please check back for a recording to our website, which is www.cfha.net. Thank you all so much for your time today.